Hello, everybody, and welcome to Learning at Lunch. I'm hoping everybody can hear me. Let's just assume that you can. So today is going to be doing respiratory anatomy and physiology. Now, we've only got 40 minutes because this is the free Zoom program, and that's as long as we can get. So let's get going. So we're going to start with the airway, which obviously starts at the mouth and the nose. But if we go from top down, let's start with the nose. So as you can see from this diagram, this is obviously a side view of the nose, and it's got some very important functions, as well as being able to allow you to smell and to breathe. The other functions it provides is that it warms the air that comes in through it. So it's lined with lots and lots of blood vessels, which makes that air very, very warm. Obviously, when you're breathing cold outside air, what you don't want to be doing is getting that going into your lungs, because your lungs don't particularly like cold air, and we'll explain why in a little while. So you've got the warming effect of the nose, and you've also got the humidifying effect of the nose. So it's a very moist atmosphere. Again, the airways do not like dry air. And you'll encounter that often with a lot of our patients. We humidify the oxygen we give them, because if it's dry, what happens is that the secretions down in their chest are also dry, and therefore very hard for the patient to actually cough up. So there's obviously two openings at the front, the nares, and then there is two openings to the eustachian tubes. And I don't know whether you can see my mouse or not, but that would be these areas here. Two openings to the eustachian tubes to allow you to equalize the pressure in your ears, and obviously the opening to the oropharynx. There is cilia inside as well as hair, which obviously catches a lot of the nasty stuff that we breathe in, but doesn't catch all of it. There is mucus in there as well, which is also useful in catching a lot of that nasty stuff that we breathe in. So when we intubate a patient, we deny them a lot of this, a lot of these functions. So, there's no humidification, there's no warming going on. So we have to compensate for that for them. So if we go down the airways, and you can see there's what called conchae here in the nose, which increases the surface area amongst other functions. So different layers again, which give a bigger surface area, allowing the warming and humidification, bigger space in which to take place. You've got the sinuses above and around the nose, and these sinuses, again, have a number of functions. One of which is to actually lighten the head, fill it with air rather than solid bone, making it much lighter. And it also makes speaking a little easier. It creates more resonance, if you like, making speaking more easy. So if we move down to the back of the airway, we now come to the pharynx. Okay, so the pharynx is about 5 inches long, starts at the back of the nose and extends to just above the cricoid. It's composed of skeletal muscle and lined with mucous membrane, and it's a passage for both air and food. Now, the nasopharynx, as you can see, is at the top. So we've got nasopharynx, oropharynx, and laryngopharynx. Fairly easy to remember: nose, oral cavity, and your larynx. So the nasopharynx obviously doesn't have any passage of food, and consequently, it's lined with slightly less tough pseudostratified ciliated columnar epithelium. If you've ever inhaled anything through your nose, hi Heather, you will know that it hurts, doesn't it? Yeah. So if something goes down your nose the wrong way, it hurts, and that's because it's not designed to go that way. Moving down into the oropharynx. Now, this is a passage, obviously, for food and air, and as a consequence, It's lined with a non-keratinized stratified squamous epithelium. Don't have to worry about that. Just know that it's tougher than the lining above it, which allows food as well as air to pass down it. And this is the area where you get the tonsils, the palatine and the lingual tonsils as well. And then we move down into the laryngopharynx, and we'll move on to that in a second. But again, this is lined with the tougher epithelium, and this is what connects with the esophagus and the larynx. So I think I've got my slides in reverse order here. So kind of covered the nose quickly. I then want to move down to this very, very important structure as far as intensive care is concerned. So this is the larynx. So imagine you're looking at the patient from the front. These are some of the structures that are really, really important. So if you look at the image on the left-hand side, this is the image that we will see when we are looking down with a laryngoscope. So if I just explain here, this part here is the epiglottis. And you can see it on this image here. This is also the epiglottis. Now, the function of the epiglottis is basically just to cover the glottis. And this is the glottis. This is just an opening. And there you can see the trachea going down into the lungs. So the epiglottis covers the glottis. Now, when I'm putting a laryngoscope in, I want to get my blade in this bit here behind the epiglottis, which is called the vallecula. And once I've got my blade in there, I then pull the blade forward, which then hopefully gives me this beautiful view. That would be considered a very good grade 1 view. I can see the cords quite clearly. I can see all the cartilages around it, and I can see actually down in the trachea as well. That would be a lovely view. So that's the epiglottis. So the epiglottis covers the glottis when you swallow. That's its function. Because what you don't want is when you swallow, you want the food to go down into the esophagus and not down into the glottis. So the whole structure actually moves up, and the epiglottis then just acts like a lid on a hinge. And as the structure moves up, it closes the lid, the hinge. So a very, very important structure. Underneath that is the hyoid bone. This is a very small bone. It doesn't attach to any other bone, provides some attachments for the tongue. And this is the bone that's often broken if people are hanged or strangled. So there you go. A good sign that somebody's been strangled is their hyoid bone has been broken. Then underneath that, you've got a membrane, which is the thyrohyoid membrane, which attaches to the thyroid cartilage. So the thyroid cartilage is this big, they call it a shield-like structure here. I'm not convinced, but there you go. There's the thyroid cartilage. So it's two plates of hyaline cartilage, and it's usually larger in the males than the females. This is what we refer to as the Adam's apple. So that's the bit that bobs up and down when we talk and when we swallow. And it kind of has the thyroid either side of it as well. So for us, probably one of the most important structures then comes underneath this structure here. But let's talk about this one first, okay? This is the cricoid cartilage, okay? So to find your cricoid cartilage, if you find your Adam's apple, so you put your finger on your Adam's apple and then just slip down to the next ring you find is your cricoid cartilage. And it's the only complete ring of cartilage, and it actually becomes slightly broader at the back. And that's one of the reasons why we press on it. During intubation, we do what we call cricoid pressure, which in theory is meant to shut the esophagus in case the patient vomits. That vomit will then go back down into the patient's tummy rather than into your tube or into the patient's lungs. So you would press on that. The structure above it is called the cricothyroid cartilage. Okay, so this area here. So if you know in the intubation process, we work through plans A to D. So A is everything normal, B is not quite so good, C is getting a bit panicky, and D is can't intubate, can't ventilate. Okay, so we do something called front of neck access or FONA. And the cartilage that you're looking for to do front of neck access is this one here. If you see those dramatic films where they stick Bic pens through the cartilage, but for us, that's what we're looking for. We would make our incision here and then put a size 6 tube in there using a bougie to get it in there if we couldn't ventilate and we couldn't intubate. So if you can't intubate, can you ventilate? Can you bag them? Yes. So you don't need to go down that route. As long as you can ventilate them, you can think again. But if you can't ventilate and you can't intubate, then you're in trouble. And this is where the cricothyroid cartilage comes in. So then as we go further down, we've got more cartilage around the trachea. It's about 5 inches long and an inch in diameter. It's got some other important functions. The cartilage is there to make sure that the airway doesn't collapse when the patient breathes in or out or coughs. It's got multiple layers, so it's got a mucosal and a submucosal layers. And the point of those mucosa is that they have ciliated columnar epithelium and goblet cells. So what that means basically is they've got little hairs on them, which waft all the rubbish back up for us to cough up, swallow or spit out. And it's also it secretes mucus. So that mucus will hopefully catch a lot of the nasty things that we breathe in, and we can cough that up as well. So that's the larynx for you. It's very, very important structure in intensive care. And if you ever do get to look when somebody's about to be intubated with the video laryngoscope, hopefully that's the image you'll see. Various cartilages around those, but you don't need to worry too much about those. That is the larynx. So which slide shall I go to next? Let's keep working our way down. Okay, so now we're working our way down the bronchial tree. So you can see the branching of the bronchial tree here. So we start with the trachea, then the main bronchus, and the secondary bronchus, then the tertiary bronchus, then the bronchioles, and then the terminal bronchioles. And this divides multiple times, about 24 times it will divide. So if we work our way down, you can see these tracheal rings working our way down, which will eventually stop because these airways are hopefully no longer at risk of collapsing every time we breathe in and out. But this is a very big airway with a lot of pressures coming in and out of it, so it's important that that doesn't collapse. And then where they divide, you've got the carina here. So the carina is where that division takes place. It's very sensitive for triggering a cough reflex. So if your patient's intubated and they're coughing, and there's nothing you seem to be able to do about it, one of the things you can ask is, where is the tube? Is it really low down and is it touching that carina? If it is, you'll often find that if it's just pulled back a centimetre or two, that makes all the difference to the patient. They will hopefully stop coughing. Now, you don't see it so well on this diagram, but what's important to remember is that actually the left main bronchus comes at a much more acute angle than the right main bronchus. So this angle is quite shallow. This is actually quite steep. And that means that when the tube is placed down, if it's gone down too far, it will invariably end up going down the right main bronchus because it's the easier angle for it to slip down into. Again, this is why post-intubation, we always listen to the patient's chest to make sure we've got equal air entry, because it may be that we can hear very little in the left and we can hear a lot in the right, and the airway pressures might be a little bit higher than they were expecting. If that is the case, then what will happen is we'll deflate the balloon, pull the tube back a centimetre or two, reinflate, have another listen, and hopefully we can hear equal air entry either side. So the main bronchi then, they've also got this stratified ciliated epithelium as well. So these goblet cells in these cilia, it's called the mucociliary escalator, which just wafts everything hopefully up. Now you can imagine if your patient isn't being humidified, then this becomes very dry and crusty. The cilia stop doing their job. They don't waft things up. It's the same with smokers. Those cilia can't do their job properly, can't waft up all this nasty stuff, and they invariably get the smoker's cough. So working our way down to the right and main bronchus, these divide to form secondary bronchi serving each lobe of the lung. So remember, there's 3 lobes on the right side, there's 2 lobes on the left side. So this division here would be the right upper lobe, this division here would be the right middle lobe, and then this division here would be the right lower lobe. Here we've got the left upper lobe and left lower lobe. Sometimes you'll hear referral to the lingular lobe in the left lung. It's not a lobe as such, it's kind of an offshoot of the lung, but just remember 3 on the right, 2 on the left. Okay. Gradually the cartilage disappears, as you can see, and the smooth muscle actually increases in those lungs themselves. So let's get even further down into the lungs now. So now we've worked our way down into the alveolar tree. Now, one of the important things to remember is that something like the first 16 divisions in the lungs play absolutely no part in gas exchange. So carbon dioxide and oxygen are not exchanged at these points. They're just moved in and out of the lungs until you reach the lower divisions. And this means that there is a certain amount of dead space where no exchange is taking place. You're just getting gases moving in and out. And let's say you were breathing 450 mils each breath. 150 mils of that doesn't actually take any part in gas exchange. It's called anatomical dead space. It accounts for your nose, your pharynx, the naso, oral, and laryngopharynx, your trachea, and many, many divisions of your lungs. So you get about 150 mils of dead space, so it's not taking part in gas exchange. Down to the alveoli. So the alveolar sac. This refers to 2 or more alveoli that share a common opening. And the important thing about the alveoli is that they have a big surface area. So they are made up of type 1 alveolar cells and type 2 alveolar cells with a nice big surface area. That surface area is really important, and I'll tell you why in a moment. So the type 1 alveolar cells you can see here form a mainly continuous lining of the alveolar wall. They've got small openings in between them, very small, very tight normally. And then the type 2 alveolar cells that you can see here, the bigger cells, also called septal cells, they secrete alveolar fluid, keeping the surface between the cells and the air moist. And this is otherwise called surfactant. And one of the functions of surfactant is to help the surface membrane pressure reduce it to stop the alveoli collapsing every time you breathe in and out. If it wasn't there, if the surfactant wasn't there, and when you breathe out, your alveoli will collapse completely. We don't want that to happen because it makes the next breath very difficult. So in a normal healthy lung, they secrete surfactant. They stop that collapse from happening. If you've ever seen any premature babies, their lungs haven't created surfactant yet. So what happens to them is that every breath is much harder for them because they've got to reinflate these collapsed alveoli, and they get this horrible chest wall compression. They get round that in neonates by literally injecting surfactant down the ET tube to change that situation. So you've got your type 1 and your type 2 cells. And outside of each alveoli is you've obviously got your capillary. So your capillary is going around the alveoli, very dense network of capillaries. And the important thing about the capillary and the alveolar wall is that they're only 1 cell thick. So there's actually minimum space between the alveolus and the circulation. and the lungs contain around 300 million alveoli. So you can imagine there's quite a big surface area there. And why is surface area important? Well, because we're trying to encourage diffusion. And diffusion relies on three different things to be most effective. First of all, it relies on a large surface area. So the bigger the surface area, the more diffusion will take place. Then it relies on a very thin membrane. The thinner the membrane across which the gas has got to diffuse, the more effective and efficient that diffusion will be. And then finally, it relies on good partial pressure difference. So what do I mean by that? You and I increase partial pressure of oxygen every day. We do that by just turning up the flow rates of the oxygen or the FiO2. So that means that you're increasing the partial pressure of oxygen in the patient's lungs compared to their circulation. So if you can imagine now in your head that we've got a slide that you might go down in a park, if that slide is very shallow, then it takes a long time to slide from top to bottom. Now we can increase the steepness of that slide by lifting the higher end up even higher, which is effectively what we're doing when we increase the FiO2. We're increasing the partial pressure of oxygen relative to what's in the patient's circulation, meaning that the gas will slide down or slide across that membrane much quicker. So just remember the important things are big surface area, nice thin membrane, and a good big difference in partial pressures. So the gas comes in via the capillary. It's been all the way around the body, and your PO2 is now relatively low, and your CO2 is now relatively high. You breathe into your lungs, which means that you've got a reasonably high PO2 and a fairly low CO2. CO2 in room air is normally negligible. When I ask people what's the composition of air and they tell me 21% oxygen, and I ask them, okay, what's the rest of it made up of? Many people invariably will say CO2. Not so. 79% of what we breathe in is nitrogen. Nitrogen is useless to us as a gas. It plays no part at all in our gas exchange, but it does take up a lot of that space of the stuff that we breathe in. So to go back to where I was, so your O2 partial pressure is now quite high in your alveoli compared to the partial pressure in the capillary. Remember, the tissues have used all that oxygen now. So it's the blood supply here has got a relatively low level of oxygen, where it's a relatively high level of oxygen in the alveoli. So because we've got a thin membrane, because we've got a nice big surface area, and because the partial pressure is good, the difference between the two, that means that oxygen will diffuse out of the alveoli and into the blood supply, and carbon dioxide will do the opposite. So the carbon dioxide is now quite high in the capillary because the tissues have given up all their carbon dioxide that they created during metabolism. It's floating around in the circulation. And so its pressure is higher than in the alveoli. So carbon dioxide diffuses into the alveoli and we breathe it out. Really not that difficult. So if you think, for example, and we'll cover some of this in later sessions when we talk about COPD and we'll talk about lung compliance, etc. If you think, for example, somebody who has got a lot of fluid in their lungs, so they've got an alveoli with, a lot of fluid lying here, that basically means that you've created a bigger membrane because now the gas has got all this fluid to get through as well, past the capillary, into the capillary, and it's going to slow down their diffusion process. So, somebody who's got lots of secretions or fluid will therefore find it harder to breathe. Okay. Right. So let's just talk quickly about, and let's start with inspiration. What happens when you breathe in? And this is quite important because one of the things you need to realize is that we breathe in using something called negative pressure ventilation, whereas our ventilators help our patients breathe using positive pressure ventilation. So what do I mean by that? Okay, so look at these airway pressures here. This is at rest, okay? And these are in millimeters of mercury. So at rest, the atmospheric pressure is 760 millimeters of mercury. The pressure in the lungs at rest is also 760 millimeters of mercury. The intrapleural pressure, remember the pleural membrane is a lining that goes all the way around the lungs. It's got two layers, the visceral layer and the parietal layer, and there's just fluid in between. And that creates a little bit of stretch anyway. It's kind of pulling on the lungs and pulling on the chest wall. So pulls the lungs out and pulls the chest wall towards the lungs, which just helps keep those lungs open a little bit. Now imagine during inspiration. Okay, so the patient's taking, or we are taking a breath in. So what happens when we take a breath in? First of all, the diaphragm contracts. So the diaphragm pulls down and the chest, the external and internal intercostal muscles contract. So the whole chest expands. Now, what that creates is a drop in pressure. If you relate pressure to volume, if you drop the pressure, you increase the volume. Well, we've increased the volume by pulling the chest out and dropping the diaphragm. So if you increase the volume, we've dropped the blood pressure in the thoracic cavity. So now our pressure drops to 758 millimeters of mercury. Our atmospheric pressure is 760 millimeters of mercury. That hasn't changed. So now there's a pressure difference between the outside air and what's in the lungs. And that means that air will then be forced into the lungs because of this pressure difference. Okay. During expiration, what happens in expiration? Expiration is actually, inspiration is an active process. So by active process, what I mean is that it requires energy. You use energy when you breathe in. Everything stretches in your lungs. The alveoli get stretched open. The pressure drops in your chest cavity because you've increased the volume. So the pressure drops, sucks that air in. When you breathe out, it's not active. You don't require any energy for that. Everything just relaxes. So the diaphragm relaxes, the intercostal muscles relax, and it relies on the elasticity within the lungs to then everything collapses down. The airway pressure now relative to outside, if we look at which diagram do we need? We look at this diagram here. So during expiration, the diaphragm's moved up and now our alveolar pressure is higher than our atmospheric pressure, which forces air out. But it's a relaxing recoil of the chest. And that's really important when we come to talk about some of the conditions we're going to talk about in later sessions, when we talk about things like COPD, emphysema, interstitial lung disease, ARDS. It's all really important that you understand that that breathing out is a relaxation process. And remember, at the start of these two slides, I said that this is a negative pressure system. So air gets drawn in because there's a drop in pressure. The pressure reduces in the chest, so it gets sucked in. Whereas what our ventilators do is positive pressure ventilation. So we blow air into the lungs. So it's completely the reverse to how we actually breathe. And that's reflected in some of the pressures that we need. In normal breathing, you can see here, there's only been a drop of 2 millimeters of pressure, and we can fill our lungs up with that. Our lungs are beautifully compliant. Compliance means, imagine you've got two balloons. Oh, no, imagine you've got a balloon and a whoopee cushion, okay? The whoopee cushion is got very thick walls, it's quite stiff. The balloon, quite thin walls, not very stiff. You blow into a balloon, it's very easy to inflate. That's nice compliance. You blow into a whoopee cushion, blowing that up, very, very difficult. That's a poor compliant system. Equally, if you then blow up the balloon, nice compliance, and then let it go, the air rushes out very quickly. So imagine this is a lung, the CO2 is cleared very quickly. Getting ahead of myself with this is another session, but let's cover it for now quickly. The whoopee cushion, yes, if you let it go, the air will come out, but the whoopee cushion will not deflate as quickly as the balloon. The balloon will scrunch all the way down. The whoopee cushion will, yes, it'll deflate, but there will still be some air left in there relative to the balloon. And that's the patient's lungs. So a patient who hasn't got very compliant lungs, breathing in requires a bit more effort. Breathing out is a bit less effective. They don't eliminate all the CO2 that they should be eliminating. Okay, so is there a slide I haven't done? Haven't done this one. So, and I perhaps should have did this in slightly the wrong order. Okay, so this is the lobes of the lung. Remember we were talking about them before? So when we talk about the apex of the lung, that's the top of the lung is here. When we talk about, we need to have a look at the apices on the X-ray, we're looking at this area up here, okay? You've got the right upper lobe, right middle lobe, and right lower lobe, left upper lobe, and left lower lobe. And you can see that they're not equal. They're not divided beautifully like you would want them to be. The right lung is shorter because it's got the liver sitting underneath it. And then you can imagine we've got the diaphragm under here, which makes the base of the lung slightly concave so it can fit over the convex area of the diaphragm. We have these fissures here. These are the divisions between the lobes, horizontal and oblique. And you've got an oblique fissure here. And obviously the heart sits in here. The pleura, like I said, is two layers that sit all the way around the lungs. Okay, so the parietal pleura actually lines the wall of the thoracic cavity, and the visceral pleura covers the lungs themselves. And between the two is a pleural cavity which contains lubrication fluid, which makes those membranes stick ever so slightly together. You don't want them to stick completely together because basically every time you breathe in and out, if they did, it would be painful. But it just makes sure that when the lungs inflate and deflate, that they slide rather than stick. Okay. So that is a very quick anatomy of the lungs. Next time, I think I'm covering COPD and some of the implications it has for the patient and for us. These are quick sessions. That's the whole point of them. It's learning at lunch. I hope you have found that helpful. Heather, I hope you found it helpful. It is being recorded, and believe it or not, we do have a YouTube channel now. So it will be going on the YouTube channel once it's been downloaded. So thank you very much. The dates are up in the coffee room. I got told off by Helen today because I hadn't told everyone. You're more than welcome, Heather. I hadn't told everybody about it, so I need to be a little bit better at letting people know that these things are going on. But they will be on the YouTube channel, and we'll put a link out to that soon. Okay. Bye-bye.